Okay, in this lesson, we're going to review the nursing implications of thrombocytopenia. So let's break down this word. Thrombocyte is another word for platelets. And then anytime you see penia, I want you to think of a lack of or too little. So thrombocytopenia is a lack of platelets or too few platelets. So by definition, thrombocytopenia is a decrease in circulating platelets less than 100,000, but usually we see it much lower than that, like less than 40,000, and we do report platelets in thousands. Now, there's a couple general causes, either decreased production, increased destruction, or medication-induced thrombocytopenia. So an example of decreased production would be in something like aplastic anemia, where the bone marrow stops producing all the blood cells altogether. Now, increased destruction can happen sometimes in autoimmune diseases like lupus, and then medications like heparin can actually induce a severe thrombocytopenia in our patients. So we'll see those decreased platelet counts, obviously, at least less than 100,000, but usually we don't start treating until they're less than 40. Now, we know that platelets are responsible for clotting, right? So if we have too few platelets in our system, we're going to see bleeding, right? Now, this kind of bleeding is not usually as severe as something like DIC, but they will ooze from all of their IV sites. They'll probably have petechiae and purpura on their skin, like what you see here. Petechiae are these tiny little red spots, and the larger ones are purpura. So you'll see those. They could have epistaxis, which is a nosebleed. They could have any kind of GI bleeding. So you could see hematemesis. You could see melena, which is blood in the stools, or you could even see occult blood in the stools where it's bleeding from a higher place. The stool looks normal, but there's actually blood in there. They could also have hematuria, which is blood in their urine, or hemoptysis, which is when they're coughing up blood. Overall, as they start to have this bleeding, even if it's a small amount in lots of different places, you're going to see their hemoglobin and hematocrit levels drop. So again, anything that would normally cause bleeding will simply cause more bleeding than normal because of the low platelets. So we could possibly do a bone marrow aspiration from one of the major flat bones. So the most common places for bone marrow is going to be the sternum, the front of the tibia, the pelvic bones or the iliac crest, both posterior and anterior. So you do that bone marrow aspiration, gives us an idea of what caused the thrombocytopenia. But usually our lab values are enough. If you see low platelets, you see signs of bleeding, then we know that that's what's going on. So we're going to give them platelet transfusions when their platelets are low enough. Now, a key thing to note here is that platelets have to have ABO compatibility just like red blood cells. So make sure that you check out the blood type compatibility cheat sheet so that you'll know what works for your patient. We'll also avoid any antiplatelet meds, especially if that was the med that caused the thrombocytopenia. So we want to avoid things like aspirin. We want to avoid Plavix or clopidogrel, and we especially want to avoid heparin. If this was an heparin-induced thrombocytopenia, we actually will consider that an allergy to heparin, and that patient should never receive heparin ever again. Then, of course, we want to put the patient on bleeding precautions. Okay, so this means electric razors only, no straight blade razors. They need a soft toothbrush so that they don't have bleeding from their gums. We want to avoid falls. I mean, we always want to avoid falls, right? But in a patient who can't clot, if they fall and have some sort of either head injury or really anywhere, those bruising and that bleeding is going to be much more severe than it would be normally. And it is possible for a patient to go home with thrombocytopenia, so we want to make sure the patient understands these precautions as well and knows how to avoid falls, especially at home. So the top priority nursing concept for a patient with thrombocytopenia is clotting. That's it. I know it seems obvious, but everything's related to it. We want to monitor for bleeding. We want to monitor lab values like their platelet count or hemoglobin and hematocrit. We want to transfuse platelets. make sure that they're compatible with our patient. And then, of course, we want to institute bleeding precautions. So everything for thrombocytopenia is all going to relate back to the concept of clotting. That's why we like concepts, because now you only need one priority. Okay, so let's recap. Thrombocytopenias decrease platelets, usually below 100,000, but like I said, typically gets much lower than that before we start treating. The patients are going to struggle to clot, and so we're going to see signs of bleeding like petechiae, epistaxis, or hemat, anything. So anytime you see hemat or hemo, think blood. So hematuria, hematemesis. You could also see hemoptysis and any kind of GI bleeding, okay? We want to replenish their platelets, give them platelet transfusions, avoid those antiplatelet medications like aspirin, clopidogrel, heparin. And then we want to monitor for bleeding, put the patient on bleeding precautions, make sure they know what to do and when to report signs of bleeding to their provider. So those are the basics for thrombocytopenia. Make sure you check out the rest of the resources in this lesson to learn more. Now go out and be your best selves today, guys. And as always, happy nursing.